Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today I'm going to make it short and sweet because I've been doing a ton of auditing. As you all know, it's auditing season, so we have, I think, actually 3 or 4 E&M audits and procedural audits going on at the same time. But I'm seeing so much, I don't know the word for it, I guess non-compliance and shortcuts taken where you're going to have some trouble. And here are just a couple of things I'm seeing just from a generic standpoint, not calling out anyone, because I want to really have you be proactive and talk to your providers about this problem because I'm seeing it everywhere. Doesn't matter if I'm doing cardiology or family practice or orthopedics or gastro or urology, and we do all specialty audits when it comes to E&M. Procedurally, we stick to our 10 specialties that we know, but it's just interesting when I see some of these things that concern me because I don't think you're understanding what the payer is looking at. I think a lot of times, or I believe a lot of times, you're looking at just, does this meet a level 4? Does this meet technically, and I'm air quoting, a level 3 or technically a level 5? The problem that's coming up is that there are not only some generic statements, for example, a patient's going to have surgery, so the risk on just the surgery, but not related to the patient outside of that. Are they on blood thinners? Are they not a candidate for surgery, but you discussed it anyway, which you get to keep your risk for whatever reason? You've got a patient that needs surgery, but they're also in stage 4 chronic kidney disease, so that would be too hard on their body to have. There's things like that aren't being, discussed within the record. The other thing I'm seeing, and this is probably the big one, is that charts are not well prepared for. And what does that mean? Well, you have a patient that you're trying to capture, it looks like a level moderate service, level 4, either new or established patient, that you're seeing either as a referral or on consult. And, maybe the payer doesn't pay for consults anymore, so you're looking at a new patient visit. But I'm seeing things that say images not available for review, records not available for review. Patient will go and try to find the report. I'm just like, what are you talking about? Or patient not bringing in their medicine bottles, so you can't, decide that. You need to talk to your staff. And for the staff that are out here, or out there listening to this podcast, I'm going to be a little chastising here because I realize I get a lot of billing, coding, and collecting staff and a lot of the revenue cycle management. But if you're a front desk, if you are somebody that prepares charts, even the electronic medical record, I know in your mind thinking, well, it's not paper anymore. No, it isn't. But when the physician sees a patient as a new patient, they need to have a completed record. If you don't have records that are available for the physician review, how is that complete? Now the patient's going to have to come back. Now the provider's going to have extra time when somebody finally finds those records, finds those images, knows what the patient's medicines are from a list, and they're going to have to now take more time, which they're not going to get paid for on a different day, to try and reconcile what's best for the patient. So it's hurting the provider, not only financially, but for a compliant note. And, I'm looking at auditing records in the aspect, yes, does this, record meet the level 4, level 5, level 3 visit? And instead, I'm now finding that, well, even though, again, technically it might meet it, it's not a complete note. And it looks like when payers see this or they require or request a formal audit, that your practice isn't doing their due diligence, isn't, assisting the providers and making sure that when a patient shows up, they've got everything they need to assess their condition, to address their problems and the complexity. And when they don't have those things, because who's ever, even talk to the scheduling desk, the appointment makers, even if you allow it online, you still have to have something on there saying you need to bring in your current medicine bottles or a list of what you're taking. And they need to know the dosages, the amounts, that, what other providers are doing for them. They need to have a list of their other doctors. If they were recently, within the last 24 months, seen at an outside hospital, if they can, let you know what that hospital is so you can get those records in advance. If they recently had an MRI or a CT scan or a heart cath or something that your doctor needs to see to be able to make a determination, it's up to the staff to make sure it's there before the visit. I'm just seeing this so many times, and it's kind of driving me crazy if you couldn't tell, because it's not a complete note. It's not a complete record. And it also has to frustrate physicians. And if you're out there not getting raises, this is one of those things. But also, if you are doing this in your practice, if you are making sure that your physicians are, well equipped, and that's the way I'm going to put it, with what they need to have a compliant note, a well-rounded record, an understanding of the patient's complexity, then now you've also got ammunition for raises, saying, look, this is what we do for you that other practices and staff aren't doing. We make sure that when you see the patient, you don't have to go on a hunt for records. You don't have to have them come back with their medicines because we're telling you. You don't have to make up information in the note. I'm not saying falsely, I'm saying guessing, because you now have it because we're making sure that it's there. So I know that a lot of things get blamed on the revenue cycle management staff a lot when things aren't paid or things are looked at or audits are triggered. And again, I'm not trying to lay blame, but I am trying to give a heads up and an understanding where this is, when it comes to patient care, it is a full 180. It's everybody. Everyone has to make sure that they are participating in that patient care, from the people that take the appointment, from the the people online, whoever your staff are that look that there's an appointment coming. What do we need to collect for that appointment as far as medical records, and alert the patient what to bring in, from the revenue cycle management staff to co-pays, deductibles, insurance cards. I mean, we are so focused on getting insurance cards and getting the payment information without getting the clinical information. You need to have all of it. And without that, it puts a hindrance on the provider, and that's not fair. So we want the providers to do their job so we can do our job. But if we don't help them do their job with making sure that they've got everything they need for a complete visit, then that's on us. That's on the medical professionals. And you make sure that you have staff that understand that process. Have a meeting. It's time. Everyone's going on vacation. It's June. This is the time to clean up those areas of, I hate to call it weakness, but I know I've seen a word used a lot. How about leakage, where there's things that are just not working well? And that's one of them. So please look into that. The other thing is that I know we also get very routine and somewhat lazy in our EMR language. And I'm starting to see, again, macros and statements that, have 30 minutes or 45 minutes on all patients. 30 minutes, that's it, just 30 minutes for, say, level 4 patients, or 45 minutes for new patients. And I'm just like, on every single patient, really? Now I'm going to go look at your scheduler. Now I'm going to go see, how many patients you saw in a day. And then when I see that, but the medical decision-making only levels at a level 2 or 3, and then I see time, and it's like, but you're telling the patient PRN a year, and you're doing great, and we don't need to see you, or PRN whenever the patient needs to come back in with no return to clinic visit because it's not necessary. It's now not a believable day. Remember, Medicare is very clear that they're going to check timed visits. Also, those macro statements can't be generic. It has to be specific to the patient. And so this is where I see that a lot of times as well. And this is just becoming such a, oh my goodness. So, it's a frustration, because we really need to understand that shortcuts are fine, but clone notes and clone statements and macro statements and smart phrases are not specific to the patient. They're not going to help if it's every single patient's getting the same thing, and it will be questioned. So, if you have an auditor like myself, whether it be payer or provider, and I do both, And we look at that. We look at the trend. All of a sudden, we're like, wait, I've seen that before. Oh my gosh, I've seen it on the last 10 records. Now I've seen it on 20. And now we halt it and go, you know what? We've got a problem here. And so that's something that it could come back to really bite you, and you don't want that to happen. So I challenge you as medical professionals out there. Even if you don't audit, even if I know some people say, well, I'm just a coder, or I'm just a biller, or I'm just this. You're never just one thing. You aren't. Think about it. If you're a biller out there, don't you want to know if what you do gets paid? That means you're also billing and collections. Don't you want to know who your coders are, so that if there's a modifier issue or there's a unbundling issue, that you can find a coder? So yeah, you're also an investigator. If you're saying you're just a coder, you're not just a coder. Don't you want to know if your codes get paid? Don't you want to know, what happens on those explanation of benefits, those EOBs, EOMBs? Don't you want to know about payer guidance? Yeah, you're also an investigator. You're also a researcher. And there's so many things that you are. You're also an educator, believe it or not. If you are not just a single staff member, even if you are, and you've got to educate providers on what's going on in the payment world, you're all educators. We all are, because we find that information, we find the published guidance, and we say, look, this is what's going on. And you don't want to invite risk. And so you have to really understand that the payers out there do something called pay and chase. So they may pay you. I just had a practice. I did a very big educational thing on for the weight loss clinics, and some of the GLP drugs, and how and I did it with my good friend Stephanie Allard, and how that's not always covered, especially if it's lifestyle medicine versus medically necessary. And we always get the same response. Well, we get paid. Just because you get paid doesn't make it correct. Under a pay and chase system, they're going to say, yeah, we might have paid you 2 years ago, we give it back. And then you've got those companies out there that payers contract with, that, they come back 3, 4, 5 years later and say, yeah, remember that patient that you no longer have in your practice, you no longer can find, that have moved out of state? We want that money back because we found you're not entitled to that. You don't want to have to deal with that situation because of these things. Okay, so because of non-compliance or generic statements, or lack of support for what you actually did that day. So it's just so important to make sure that everyone's on the same page. Everyone continues to take pride in their position, whether it be coder, biller, collector, front office, appointment scheduler, back office. It doesn't matter. You're all parts of, let's just say, a moving car. And if you've got a flat tire, or you've got an oil leak, or you've got a transmission problem, pick a department. Then that car is not going to work well. It's not going to drive safe. It's not going to be okay. And it's going to be on the side of the road waiting for somebody to pick it up, and most people will pass it by. And so it's really important to understand these things and make sure that you are on top of it. And as we head into the summertime now, we are close to I think we actually are the first day of summer. Is next week, is the 20th, actually coming this Friday. It's just so important that you really kind of go back to basics with staff, go back to basics with providers, go back to basics with your EMR vendors, and say, okay, here's what we need to tighten up here, because this is a problem. And it'll just, in the long run, it'll keep you from that pay and chase situation. Okay, well, I know I've kind of been on a soliloquy this morning, only because I just feel like this has never really gone back to and talked about. We always talk just about, well, here's your code. And I am going to get back to coding next week, but this really, the Codecast podcast, we talk about coding, billing, compliance, and everything that's going on in the healthcare industry. And it's just so important to make sure that we are all contributing as, a fine tune to not only help our providers be successful, but to help ourselves be successful, especially if you're going to branch out, as a consultant, if you're going to pick up extra specialties, if you want to move up in your own practice. You need to first perfect what it is that you do. Okay, it doesn't matter what level you are in your practice. It's important as everything that everyone else is doing as well. So I hope everyone takes it to heart. Love to get any feedback. Also, as a reminder, please give us and drop us a rating and review on any platform that you listen to, Apple, Spotify, Amazon, anywhere. We appreciate that. So thank you for listening to the 400th episode of the Codecast podcast. Make it a great day.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.